Hey guys, this is Charles. I hope you guys are enjoying the spring semester. Dr. Joe had asked me to make a brief 15-minute video talking about some the cardiology topics that you'll be getting into MedSurg, and I hope you enjoy this video. So the first question that she had asked me is, what are the 5 most common diagnoses that I see where I practice? So I work at a Piedmont Atlanta cardiovascular ICU, and the 5 most common diseases are: one's multivessel coronary artery diseases, number 2, valvular diseases, number 3 is heart failure due to maybe dilation or hypertrophy, 4 is abdominal aortic aneurysms, and then 5 are heart transplants. So for the first one, multivessel coronary artery diseases, the treatment of choice, if they need surgical intervention, is cabbages, what we call cabbages. So that's coronary artery bypass grafts, where they take grafts from your leg or inside of your chest and then make a bypass of the occlusion. So number 2 for the valvular diseases, so this is the most common we see is aortic valve repair replacements and maybe mitral valve repairs. And those are mostly due to maybe extreme hypertension. When people live with hypertension for a long time, increases the afterload, so the heart has to work harder, and it can lead to faulty valves. And sometimes it can also be due to genetic disposition and reasons. Number 3 is heart failure due to dilation or hypertrophy. Again, the heart, when it has to work against hypertension, and when hypertension is not managed correctly, due to various reasons, people may not be compliant with the medications or may not be able to afford their medications. So when they live with this for a long time, again, the heart has to be fed harder, and it either may be too thick to work properly or too thin and dilated to work properly. And a lot of those patients, they get what we call LVAD, so left ventricular assist devices. So those are like basically pumps that are placed at the apex of the heart, and then there's a pump. The newer ones have magnetic pumps, so there's less friction in the blood, and it really does a fantastic job of pumping the blood, helping the blood go forward flow out of the heart and into the rest of the body. Next one, number 4, talked about is abdominal aortic aneurysms. So these are pretty complicated cases because the chest has to be open, and then the valves, not the valves, but the aorta, which in most cases can go behind the heart. So the surgeon has to actually go behind the heart and put in grafts on it. And when you look at the X-rays, it's really fascinating. It looks like an elephant trunk. You probably see that in your books, but when you really get to see it in the X-rays, it's really fascinating. And then number 5 are heart transplants. So we got a new surgeon at Piedmont, and his goal is to do 100 heart transplants a year. And I think we're already at 50, and he's only been there a couple of months. So we're doing a lot of heart transplants. These are very challenging patients because there's a lot of labs that we have to draw, a lot of procedures that has to be on time. And then after that, managing those transplant patients, arrhythmias, anti-transplant medications, and also psychosocial issues, because these patients, it's someone else's heart inside their body, so they're very stressed. They're feeling very thankful, but then also feel guilty because someone had to pass away to get their heart. So there's a lot of things that we as nurses have to deal with that side, and that we help them try to manage. So your instructor, Dr. Joe, had also asked me to talk about some things like what are the common medications that we see. So there's a lot of titrations of critical care medications, like inotropes, like dopamine, dobutamine, and melanome. And then epinephrine drips are very common at Piedmont. And then they may need some blood pressure support, so such as norepinephrine, also known as levo, and vasopressin. And sometimes they may go the opposite way. They may have very extreme hypertension, and we may need to relieve it. That's especially true of the aortic aneurysm patients. if we don't relieve the hypertension, it can actually hurt the grafts. So we have to manage it by carding. And when they come out of the OR, they're sedated, so of course they're going to be a propofol. And then pain control is really important because these patients, they literally had their chest split open, so they're going to be in extreme pain. And if you don't control that, they're going to have very shallow breathing, which is going to hurt their lungs and then hurt their recovery. So it's really important that we manage their pain through narcotics such as dilaudid and fentanyl. And last but not least, what critical nursing care a prudent nurse should provide to these patients. Obviously, with those drips, the overall goal is hemodynamics. So getting the optimal amount of blood to come out of the heart and perfuse the body. Because in cardiology, critical care, and especially CVICU, what we're really concerned about is perfusion. So perfusion to all the cells, the rest of the body, and that can only happen when your lungs, heart, and maybe assistive devices that they may have all work together. So as nurses at the bedside, we have standing orders and parameters that we work with, and we make sure that the blood gets to the body, the oxygenated blood gets to the body, and then if there's a problem, then we coordinate with all the providers to provide the best care. And just a brief perspective about some real life experiences that I had. So when I went into critical care, I didn't realize how important therapeutic communication was. There's a little joke about, ICU nurses that, a good shift would be just our 2 sedated patients. But if you're working in critical care, especially these days with COVID, and especially a post-operative care, therapeutic communication is very important because you want these patients to get better. The goal is to get them off the sedation, off the drips, up to the chair, on their feet, and on the way, because many scientific studies have proven that the best way to have the best outcome for these patients is to quickly get them off sedation, quickly get all the lines out, and quickly up to their feet and moving about. And like I said before, these patients, they just had their chest open, or maybe someone else's heart inside the heart. So a lot of therapeutic communication is required of the nurse. So that means like anticipating their care, telling them what's going to happen throughout the week, and then continuously encouraging them, and just little things like saying, hey, Mr. X, I'm going to step out for like 15 minutes to do some other things for my other patient, but I'll be back in 15 minutes with that pain med so that we can do X, so and so and so. So you got to do that like constantly throughout your shift. Even though I work night shift, a lot of these patients, they don't sleep, and especially at Piedmont, it's progression of care, progression of the patient's health, even at night shift, and especially on day shift. That is the expectation. So night shift does not mean that you sit down and then you just watch your patient sleep. No, there has to be progression of care always. Otherwise, if you have any questions, you can email me, ask me any questions. My name is Charles Lee, registered nurse at gmail.com. Otherwise, I wish you the luck, very best luck for your spring semester in MedSurg. See ya.